Good evening, everybody. Myself, Dr. Renji, Senior Consultant, Physician Rajagiri Hospital. I would like to congratulate Dr. Paramesh for that crisp presentation detailing about the newer developments in asthma. And today, from our side, in this late moment, we have our two budding physicians, Dr. Veena and Dr. Ashwadi, who will be presenting before you two short, interesting cases. So I have told them to make it short and sweet so that you can enjoy it. And we'll go to the presentation.
Good evening, one and all. My name is Dr. Veena. I'm a resident DNB at Rajagiri Hospital. So I have the honor to present before you an interesting case that we came across of an apsoclonus myoclonus ataxia syndrome. Now the patient was a 64-year-old gentleman hailing from Chalakudi who was a shopkeeper by profession with a past history of type 2 diabetes for which he was on an OHA for about 4 years. Now, when he presented to us, he presented with a subjective rotatory sensation for 4 days with no diurnal or postural variation. It was not associated with any ringing sensation in the ear or hearing impairment, lasting for approximately 3 to 4 minutes at a time, associated with nausea and vomiting. He also complained of difficulty walking as well as bilateral jerky movements of upper limbs and lower limbs. He described the jerky movements as involuntary, almost arrhythmic, not associated with loss of consciousness, not at the same time as the vertigo, and there was no other aggravating or relieving factors. Now, he gave also a history of headache for the last 4 days, which was more or less a band-like sensation with no associated photophobia or phonophobia, which was relieved on taking analgesics. It was not associated with fever. Again, no diurnal or postural variation for the headache. Now, at the time of presentation, he gave no history of fever, cough, associated gastrointestinal symptoms, no visual deficits, no history suggestive of dysphagia, dysphonia, or dysarthria, no history of intake of ethanol or any other medications in the past. Now, on examination, his vitals were within normal limits. He was afebrile. On general examination, we had noted that there were monomorphic multiple tan to brown maculopapular rashes all over his upper limb as well as the trunk, not as much over the face or on the lower limb. And on further examination, Darier's sign was positive for these macules. That is, on irritation, there was urticarial patches that appeared over the rash. And on systemic examination, in the central nervous system, patient was conscious, oriented, cooperative. Higher mental functions were intact, no motor deficits. Bilateral reflexes were normal with flexor plantar bilaterally. Patient was also showing some chaotic, jerky, multidirectional eye movements, which was suggestive of an apsoclonus, as well as truncal ataxia. No other cerebellar signs were present and no sensory deficits could be appreciated. All other systems were within normal limits. Now, at this point of time, we had the following complaints. We had a truncal ataxia, we had an apsoclonus, history that was suggestive of more or less a myoclonic jerk. Now, our anatomical localization at this point was a probable lesion in the cerebellum or brainstem, and pathologically, etiologically, we were thinking more or less in the line of paraneoplastic, because an adult in the age group of 60 presenting with an apsoclonus myoclonus ataxia syndrome, the most probable cause would be a paraneoplastic syndrome. Now, so there are 3 main causes for apsoclonus myoclonus ataxia syndrome, that is paraneoplastic. In this case, we had also appreciated the possibility of mastocytosis because of the positive Darier's sign, as well as the urticaria pigmentosa over the upper limb as well as the trunk. And another possibility that usually occurs is it happens as a prodrome, a post-viral prodrome, but there was no history of fever in this case. Now, an alternative diagnosis that we had entertained initially was a posterior circulation stroke. Now, in this light, we did our preliminary blood investigations, which were pretty much unremarkable. Going on to our radiological investigation, initially we had done an MRI brain. Now, on the MRI brain, there were no intracerebral lesions, there were no signs of a stroke per se, but there were an uptake in the clivus, pterygoid process, sphenoid, ethmoid bones, as well as on the MRI spine, there was a diffuse uptake in the spine, which is suggestive of a infiltrative marrow disease. Now, at this point, considering an apsoclonus myoclonus ataxia syndrome, possibility of a paraneoplastic condition, we were thinking more or less in the line of multiple myeloma. So, in the follow-up specific investigations, sorry, I'll come back to the CCT abdomen and chest. So, considering that we had done, in the meanwhile, a protein electrophoresis, which is negative. We had also done a calcium parathyroid hormone assay, which is also within normal limits. Now, to find any possible primaries, we had also done a CCT chest and abdomen, which is again negative. Now, following which we had done a CSF study, a bone marrow, as well as a skin biopsy from the lesion. Now, the the CSF study was suggestive of a slightly raised CSF protein as well as a mild lymphocytic pleocytosis. And now the histopathology of the bone marrow is where it gets interesting. Bone marrow biopsy was within normal limits, but the aspiration was within normal limits, but the biopsy was suggestive of a multifocal mast cell infiltration, which accounted to be about 18 to 19% of the sample that we had gotten. And the immunohistochemistry was positive for CD117, which is a marker for KIT gene, that is mast cells. And the biopsy that was taken from the skin also showed multifocal mast cell infiltrate, suggestive of a mastocytosis. And as a confirmatory test, we had also sent a tryptase level, which came back to be 125, which is also significant in this case. Now, as the management for the apsoclonus myoclonus as a paraneoplastic, we started him on pulse steroids. He was given methylprednisolone for a total of 5 days, on which his symptoms started coming down. Meanwhile, we had gotten the reports of the bone marrow as well as the skin biopsy and the tryptase level. So we started him on mast cell stabilizers as well as antihistamines. Now he is under our follow-up. After 1 month, we were able to completely taper him off the steroids. We had discharged him on oral steroids. So we completely have tapered him off the oral steroids. And the mast cell stabilizers he's still on. Now it's been 7 months since he presented initially. Now in the last follow-up, which was a couple of days ago, he's completely back to normal. His neurological deficits are, he doesn't have any neurological deficits. He haven't had any symptoms per se of the systemic mastocytosis either. Now this is the advice that we have given. We routinely follow up his blood works. In case there is any progression of the disease, we plan to start him on avapritinib or midostaurin. And if he's not able to afford, we can also start him on cladribine. That is after a detailed study to see if he has any KIT mutation. So this is our plan. He is at the moment completely fine on mast cell stabilizers.
So in this patient, what is interesting is one is mastocytosis, which we come across once in a while, and the other is the paraneoplastic presentation, patient presenting as a neurological case. So linking those two are very rare, I think. That is the interesting part about it. So searching for a paraneoplastic syndrome and the focus, we ended up getting into mastocytosis. And can you tell something more about the mastocytosis part, its presentation and all this?
So mastocytosis or systemic mastocytosis happens about 1 in 10,000 to 20,000 is the frequency that we see in 10. Cutaneous mastocytosis is more common. It's seen more in the children. Systemic mastocytosis is the most common presentation in case of adults. It is very rarely presented as I've mentioned as a paraneoplastic. So usually the presentation that comes is repeated anaphylactic attacks, dizziness, hypotension, orthostatic hypotension. Patient can also, but usually drug allergies are rare. It's mostly towards allergic reaction to food is what it usually presents as. So it is mostly due to infiltration of atypical mast cells into the liver. It can infiltrate into the bone marrow, liver, as well as spleen. So we can classify it as different groups. So there is, our patient had a smoldering systemic mastocytosis because there is bone marrow infiltration, but the outright symptoms were not there, and the the atypical muscles were around 28%. So it has to be a much higher level, more than 30%. And if there were any pancytopenias or something associated, we can say it is a outright full-blown mastocytosis. Now, the thing that gets tricky in case of mastocytosis is that it is more or less a pre-malignant condition. It can progress onto a mast cell leukemia or a systemic mastocytosis associated with any hematopoietic malignancies. So in these patients, the tricky part is to make sure that they understand the need for follow-up. So we'll have to follow up and see if the patient develops any hepatosplenomegaly, if the patient develops any cytopenias in the future. And in that case, we might have to repeat a bone marrow biopsy, and we might have to further work him up to see if there's much more spread. And at that time, we'll have to start him on a KIT inhibitor. So that is the most common involving codon is 816. So it's a key KIT V816 mutation antagonist is this avapritinib and midostaurin. In case the patient doesn't have that, which happens rarely, it can also be treated with imatinib. So the most common is midostaurin. The rare one is imatinib. So this is our plan. This is the briefly about systemic mastocytosis.
So mastocytosis as such should be considered as a pre-malignant condition. So that's the importance of going for this paramyeloplastic. Searching for it would be fruitful. So I think any queries regarding this, or we'll go to the next case.
So they say that the tryptase level can increase during anaphylaxis. So usually when we diagnose systemic mastocytosis, we say that we have to take the tryptase after, like at least a week or two after the current current event, because
tryptase levels as early as possible.
yeah, because again the levels
persistent elevation in tryptase, I think we should suspect.
Yeah, we have to suspect. And another thing is that if the tryptase level also has some correlation. So if it is more than 200, so the range is less than 20 is the normal range. So 20 to 40, we can diagnose a systemic mastocytosis with all the other conditions. But if it is more than 200, again, the significance of it being progressing to a neoplasm increases. So that is also the significance of serum tryptase. Irrespective of it, if it is more than, this is a very high level, so it is pretty significant. So if it is in that borderline level, you can repeat it after the event to see if it is still persistently high. So that is one significant thing about serum tryptase. The only problem is that it took us a while for the report to come back. So
mastocytes usually, because it's directly related to allergies, it is mostly lines the lungs or the skin or the intestine. So all these organs will be primarily affected. So all those people who will be dealing with those organs, especially you also would have seen more cases in. Yeah, self-injected adrenaline, they have to be prepared with it. But we have previously seen with severe cases of anaphylaxis requiring vasopressors and everything. So it's a very scary situation for them. But I haven't seen patients progressing to malignancy as such, even though we have followed up.